Welcome to Grand Rounds. My name's Tom Farden. I chair this thing. We are live to Perth Royal Infirmary. It's a bit dingy over there. I'm not sure how many people are there, but if you can hear us... Oh, there you go. And now they've left. Okay. If you are there in Perth, could you turn your microphones off for the duration of Samira's talk? Otherwise we can hear you cough and splutter. Maybe they have, maybe they haven't. Today is the last grand round of this semester, and much like the last day of the season, we have a good turnout. So thank you very much for coming. This week is Acute Kidney Injury Awareness Week, and we'll hear more about that from Samira Bell, who has been on the television this morning, she tells me, on STV, so look out for that later. First of all, you should hopefully have received the New Look Grand Rounds newsletter, which we're trialling a piece of software that means it's not me dependent. And if you're not on the distribution list at the moment, if you go to the college website, you can click the button that says subscribe me to the list, so you should get the messages every week. In the news, this is Professor Bruce Guthrie, and he's just published the results of a 15-year study of 310,000 Tayside residents, and says that a rising tide in the use of prescribed medications and potentially serious drug interactions raises significant concerns of adverse drug reactions that need to be addressed by more research. So 15 years is not enough, we need another 15 years. I suspect many of those interactions are renal in nature, and perhaps we'll hear about that in a little while. Professor Bob Steele, who's been distracted by a mouse in the corner of the room here, is also in the news. His team have launched a research project to develop a new risk score for patients that could lead to a more effective identification of those at risk of bowel cancer. The National Student Survey continues on our parish notices. If you're a fifth-year medical student, please complete this, as you have a chance to win an iPad, or you can go to the University Grand Ball. We are over 80% now, but we'd like to get up to 100% and catch those pesky dentists. On Tuesday the 5th of May, Dr. Michael Gordon, a distinguished geriatrician and palliative care specialist from Toronto's Baycrest Centre, is here to deliver a lecture entitled Managing Ethical Challenges in Late-Stage Dementia. So one to look out for. He's come a long way to present here. On the 7th of May, in here at 5 o'clock, the Tenevus Committee hold a scientific evening with presentations from some of our own Tenevus grant holders who will explain what they've done with the Tenevus donations and what they plan to do in the future. All inquiries to Victoria Borthwick, whose email address is on the screen. The Farr Institute are still having their research day in St Andrews. If you've not already signed up, the website is on the screen. I spoke about this briefly last week, and I'll drip feed some more information for you, that the Archie Mountain Challenge is happening between the 30th of June and the 21st of July. We have 3 family walks. So you can, if you don't want to do the craziness of cycling and fell running, you can come on a family walk on the first day, which I think is Ben Eam, and then you can go up Schehallien in the middle of the week, and at the end of the challenge, there's a walk up the rest and be thankful. We're still doing our crazy Archie in space cycling endeavour. We're still trying to climb 100,000 metres vertical ascent to reach space. We now have agreement from the Abernite Antiques place, and there's going to be food and drink, excitement, and there might even be a tombola. This is the climb. You can check all our training on there, and you can see that despite my best efforts, I'm still 5 seconds slower than the fastest girl, who is one of our medical students. Dundee Grand Rounds this week. To finish off the season, Samira Bell will talk to us about acute kidney injury. Don't come next week. It'll be very quiet in this room. But we do start again on the 14th of May with Sarah Ulstaff from Sexual Health, whose talks are always worthwhile coming to. You never quite know what you're going to get with Sarah. But this week, Samira Bell will talk to us about acute kidney injury. And I will grab my spelt salad. Darker? Don't want to see you.
No.
Keep going, I'll try and make it lighter.
Okay, thank you. So I'm going to talk a bit about acute kidney injury, and basically we're running an acute Kidney Injury Awareness Week this week to launch 2 initiatives in Tayside, which I'll mention later on in my talk. So firstly, I'm going to start a bit about the epidemiology of acute kidney injury. The definition, which really since 2009 has come into play and allowed us to get a better idea of acute kidney injury and its epidemiology. Why it's important. The National Confidential Inquiry into Patient Outcome and Death Report, which highlighted deficiencies in the care in hospitals of acute kidney injury, and the 2 initiatives that I mentioned, which are sick day rules and the electronic alerts. So, as I said, we didn't really know what the true epidemiology of acute kidney injury was because there really wasn't a definition out there to clearly define it, but it was reported to range from about 2,000 to 4,000 per million population in developed countries. It's very common in hospital, affecting up to 20% of patients who are hospitalised, and extremely common in the intensive care setting, affecting up to 67% of patients. The recent evidence suggests the incidence is rising, but we're really not clear why. And is this because there's a greater awareness of acute kidney injury? Is there more of it about? Or is it because there is an older population which is more likely to get acute kidney injury? So when you look in the literature, certainly when I was a student, there's lots of different definitions of what was previously known as acute renal failure rather than acute kidney injury. And some of these looked at urea and creatinine, some of them looked at urine output, some distinguished patients with pre-existing CKD and some didn't, and some defined acute renal failure as the need for dialysis such as hyperkalemia, fluid overload and uremia. So initially, some of you may be aware of the RIFLE criteria, which was then modified by the Acute Kidney Injury Network group and now is endorsed by Kidney Disease Improving Global Outcome guideline group, and it's categorised acute kidney injury into 3 stages, and this is really so that it's a spectrum of disease ranging from mild disease to more severe disease. So stage 1, and I've colour-coded these because later on you'll see that this is relevant to the alert system that's implemented in ICE. So stage 1 is a rise of 26 micromoles per litre, or 1.5 times the baseline creatinine to 1.9 times the baseline creatinine. Stage 2 is 2 times the baseline creatinine to 2.9 times the baseline creatinine. And stage 3, which you might not be able to see, is 3 times the baseline creatinine, a rise to creatinine of above 354 micromoles per litre, or the need for renal replacement therapy. As you can see alongside it, there is also urine output criteria, but I think in clinical practice, certainly even in our wards, it's difficult to get accurate urine output measured. That it's more practical to use serum creatinine-based criteria. So why is it important? Why should we pay attention to acute kidney injury? Well, mortality can be really high, particularly in patients who have multi-organ failure, and it can be up to 80% in those requiring renal replacement therapy in the ICU setting. But the definition has allowed us to see that even small transient rises in creatinine as small as 26 micromoles per litre are associated with an increased mortality. And several studies have shown this, that as severity increases, your mortality increases. A meta-analysis of 48 studies showed that an AKI of any severity was associated with a doubling of long-term mortality compared to individuals who haven't experienced AKI. And you probably wouldn't expect to find that a creatinine rise of 26 micromoles per litre that's only transient really does have adverse long-term outcomes. So I just wanted to show some data from Tayside as well. So this is a problem for us here, and it's not just from these studies that you see reported in the literature. So we looked at 10,600 patients undergoing orthopaedic surgery in Tayside, and we looked at survival. Over the period of time, which was the median follow-up of 4.5 years, 30% of them died, which is 3,166. And when you look at the survival, the unadjusted and adjusted, and what we adjusted for was what we could adjust for, which was age, sex, diabetes, baseline renal function, and number of medicines, which we used as a proxy for comorbidity. You can see that short-term 90-day survival is significantly poorer, as is 1 year and long-term survival too. When you look at it like this in this Kaplan-Meier, this is survival in these patients according to stage of AKI, and the blue line are patients without AKI at all. The green line is stage 1. Bearing in mind again that this is can be a creatinine rise as small as 26. There is a significant difference in survival in our patients, and I think the reason why 2 and 3 is sort of kind of overlapping is because the numbers are much smaller in those groups. Another long-term consequence of acute kidney injury is the risk of developing chronic kidney disease in the future. And this table really highlights a number of studies that show that if you've had acute kidney injury previously, that your risk of developing chronic kidney disease in the future and or being on renal replacement therapy is higher. So another important aspect of this is the cost implications of acute kidney injury, and patients who have acute kidney injury during their hospital stay will stay an average of 4.7 days, and the costs are estimated to cost the NHS between 434 and 620 million per year, which is higher than the costs associated with breast, lung and skin cancer combined. And it's estimated that 30% of all AKI is preventable and avoidable, and this would save the NHS between 130 million to 186 million per year. So there really is, this is an area that can be targeted. In terms of treatment, really there are no specific treatments for acute kidney injury. And that's why prevention is really vital. Renal replacement therapy is really only supportive, and it will support the kidneys until they begin to recover. And what we really advocate is that early identification and avoidance of further injury in terms of fluid resuscitation, treatment of sepsis and avoidance of further insult is the way forward. So I'll just mention a bit about the National Confidential Inquiry into Patient Outcome and Death Report, Adding Insult to Injury. And this was done in 2009, it's a bit old now, but it reviewed the care of patients who died in hospital with a primary diagnosis of acute kidney injury. The main findings from this report was that they found that only 50% of care was considered to be good by the advisors who reviewed the cases. They felt there was poor assessment of risk factors for AKI, in the assessment of patients who had established AKI and those who developed it while they were in hospital. They also felt there was an unacceptable delay in recognising post-admission AKI in 43% of patients. A fifth of post-admission AKI, in their opinion, was predictable and avoidable, and they felt that the complications were missed in 13%, avoidable in 17%, and managed badly in 22%. So it really wasn't very good findings that they discovered from this. So on the back of these findings, they came up with a number of recommendations, and that initial clerking of emergency patients should have a risk assessment for AKI included, that all patients admitted as an emergency, regardless of specialty, should have their renal function checked routinely and appropriately thereafter, and they felt that this would prevent insidious unrecognised onset of acute kidney injury. They recommended that predictable and avoidable AKI should never occur, which is obvious, and for patients who do develop it, there should be a robust assessment of risk factors and awareness of the possible complications. And they made some recommendations based around training as well for both undergraduates and postgraduates, including the recognition of patients, sick patients, and the prevention and diagnosis and management of acute kidney injury. So on the back of that, there's been a lot of work around acute kidney injury in England and Wales, and we're beginning to follow up here as well. And what can we do here in Tayside? So we felt that raising awareness of this problem, because I think it's not something that people are hugely aware of, the long-term consequences, and doing this really through education But the two initiatives that we wanted to implement as part of this, firstly was the 6-day rules, and secondly are electronic alerts for acute kidney injury. Now these have been implemented widely down in England, but nowhere else in Scotland has implemented these as yet. And I think by June of this year it's mandatory in England to have these electronic alerts for acute kidney injury in their hospitals. So this was our way of raising awareness. So we've been running Acute Kidney Injury Week this week. We've been outside level 5 with our stand, annoying everybody that walks past, and giving out freebies. We've been going around the wards with a tea trolley and cakes, targeting nurses and junior doctors and going through short presentations, education presentations, to try and spread the word. And we found this quite an effective way. I think people are willing to stop for a cake. But it has been quite a large undertaking getting around all the wards, but it's been a combination of our medical staff and specialist nurses and students. So this is our guideline. I don't know if many people are aware of it. It's a very simple one-page guideline that's on the intranet, and it's really designed for the junior doctor or whoever to help them when they have an alert generated or if they're worried about a patient with acute kidney injury. So the first part is of the guideline looks at identification and being aware of which patients are high risk for acute kidney injury, and it's really any patient that's unwell. If they're hypotensive, if they're hypovolemic, if they've got sepsis, if they've got deteriorating SUS, have they had contrast in the last week? Have they had any particularly bad drugs such as ACEs, ARBs, non-steroidals or COX-2 inhibitors? Also, when you look at the risk factors for developing AKI, and these are taken from the NICE guidance, it's pretty much most of the patients that you see in hospital. So people with any pre-existing CKD with a GFR of less than 60 mils per minute, people above 65, diabetics, people with peripheral vascular disease, and people with any kind of comorbidities such as cardiac or liver disease. If a patient has had AKI before, they're more likely to get it again. So again, this puts them at risk. Recognising AKI, and now that the e-alerts, which we'll talk about later on, will really help people make that detect it earlier. When you're coming to investigations, again, it's simple things. Full history, examining patients for fluid status, sepsis, do they have a palpable bladder, and all the basic investigations that patients will get done when they're in, including a urinalysis. And then the more specialist investigations if you're suspecting intrinsic renal disease such as an ultrasound or immunology, myeloma screen. In terms of the treatment, all we're wanting the junior doctors to do is really fluid balance assessment, resuscitate patients if they're dry, and if they're not, then consider that they might need level 2 care, stopping nephrotoxic drugs and avoiding all future nephrotoxic drugs, treating sepsis with appropriate antibiotics, and then think in patients with acute kidney injury we're not keen for further doses of gentamicin. Also, we have problems with trimethoprim and cotrimoxazole because we often have patients that are admitted to us having had prolonged courses of trimethoprim from the community with CKD on an ACE and an ARB, and they come in with life-threatening hyperkalemia, and you wouldn't really think that that would be a big problem, but it is something we do see a lot of. Avoiding contrast if possible. If not possible, we have got a guidance on contrast, preventing contrast nephropathy. And the indications for referring to us are all AKI 3, significant hyperkalemia, resistant pulmonary edema to diuretics with AKI, oliguria and deterioration despite doing the above things, or suspicion of a renal disease. We also like to know about all the transplant patients with AKI, or transplant patients in general that have been admitted, and patients with stage 4 or 5 CKD that have an AKI. But we're happy to talk to anybody about anything, so just get in contact with us if there are any concerns about any of your patients. That was the renal prophylaxis guidance for CT scans with contrast. That's on our renal pages of the intranet as well. if you're looking for it. So, Kidney Sick Day rules, this was one of the initiatives that we've launched this week, and NHS Highlands launched this a few years ago, and it's been launched down south as well, and it's basically a card that's been given to patients so that if they're unwell with vomiting or diarrhoea or fever, shakes and sweats, that they stop taking their medication, which this is on the back, the list of medication. And this has been rolled out to primary care, to all the GP practices, and we're hoping for it to be distributed to the outpatient clinics as well, and secondary care, the relevant ones. And the hope is that we can avoid the typical scenario where we have our elderly patient that comes in with diarrhoea and has religiously taken their medication throughout the episode, and they've got severe AKI with life-threatening hyperkalemia. So I'm just, unfortunately Bill Bartlett isn't available today to talk to you about e-alerts. I'm going to pass over to Tani, one of our registrars, who's going to talk you through the e-alerts, what they look like and how to manage them.
Hello everyone, I'm Tani, I'm one of the registrars in Renal, so I'm going to talk a wee bit about the e-alerts, the more practical aspects of managing them. And a lot of you have probably already been annoyed by me this week a lot because I've been going along to all the wards harping on about it. So the e-alerts were rolled out from Monday, so most of you a lot of you might have seen one or two of them, hopefully in AKI 1 or 2 and not in AKI 3. And they were developed by Dr. Bartlett and his team, and Dr. Bartlett was actually on the team that made the original algorithm. And this algorithm has been recommended by the Department of Health in England to be rolled out, as Dr. Bell said, to all hospitals in England and Wales, but as yet there's no recommendation for Scotland. How the algorithm works is by automatic comparison to the latest creatinine results, and if you have a creatinine result within 7 days, it will take the lowest creatinine result. If the creatinine result, the previous one, is between 8 to 365 days, so within the last year, it will take a median of those results. If the last creatinine result is much further back than that, so within 3 or 4 years back per se, you won't get an alert generated, but you'll get the old-fashioned note on your ICE result that you would have got anyway, saying, consider AKI, consider CKD in this patient. The last thing to say, and then the next slide. So the alerts are a tool for you, so they're not something that gives you a diagnosis. If you have a patient has been sitting there anuric, you're not going to sit and wait for their creatinine to rise by 26.4 nanomoles until you say that this is an acute kidney injury. And obviously all they're doing is indicating that this patient needs a review to see if an AKI is a clinical diagnosis that you would make. You've always got to consider other causes for a raised creatinine as well. For instance, earlier this week there was a AKI 3 generated on one of the MFE wards because on Monday the patient had their blood labels were incorrectly labelled with a different patient's blood result, so it looked like their stable CKD4, their creatinine had gone 200, 200, 65 back to 200. So that wasn't a true acute kidney injury. The other common consideration is drugs like trimethoprim and nitrofurantoin that can increase your serum creatinine without a drop in your GFR. So this is how an ICE screen, if you search for your patient, will appear. This is a test patient, Laura Blarowski, poor Laura's been through a lot this week. She's had a lot of AKI 3s. If you see just this little icon here, that signifies that she has an alert, an electronic alert, not necessarily an AKI alert, not that there are any others just now, but an electronic alert next to her name. And then when you click on her, by clicking on her patient information and on the alert itself, you can get further information. When you click on her and go into her results screen, or your patient's results screen, there will be a coloured banner going over the top of their information that'll signify the level of alert, which I'll come on to. And to get on to the actual details of the alert and also how you do something about it, you click on the alert box just here. And what will come up is this thing here. And I'll go through all the different things that you can do. The next slide just shows you the different stages of the alert, and this relates directly back to Dr. Bell's KDIGO classification of AKI 1, 2 and 3. The important thing, the hope of all this is because AKI 1 is a much smaller rise in creatinine than sometimes we notice, that sometimes we do something about. Historically in the NC-POD, the kind of blurb at the start of that report goes on about circling blood results over the weekend and something being done about it on Monday morning. So that's what we're trying to encourage, is action at that level, at that small rise of acute kidney injury, to stop it progressing to anything more, because the insult is still there, and if you deal with the insult at that stage, hopefully it won't get any worse. So the first thing is, this is the alert box, and this is all the things you could do. This little thing that says AKI stage 3, or it would also say AKI stage 1 or 2, depending on which stage it was. If you click on that, it will take you straight to the Renal homepage, and that will have all the guidelines that you need to be able to properly assess and manage your patients on that homepage. It has the hospital AKI guidelines as well as the community AKI guidelines, and if you also need it, the contrast prophylaxis guidelines. So this is the hospital guidelines, which Dr. Bell's gone through in lots of details. It's all very simple stuff, but sometimes the difficulty is getting it in some sort of order. When we're looking at the AKI 3s, the renal team do want to know all about every AKI 3, but sometimes, especially if you're phoning from Perth, those 3 people, or something like that, the difficulty with a phone call is that it's difficult to get the right information across. But if you've looked at your patient, actually gone to your bedside and looked at your patient and gone through the things on this guideline, you should be able to give us the right information on the phone. This is the community guideline. So these alerts will also, for those people that use ICE in the community, will also be generated to ICE users in the community, and they can look at this guideline instead. So the things that you can do with the alert, so the first thing we talked about was clicking here and being able to link to the guideline. If you click the edit button, you could add little notes to yourself. So these are just, notes to help you if you think that you can, they might remind you or your colleagues something about this patient's care. So you can add a little note and OK that, and all those notes you will be able to see later. What we actually very much want you to do with your alerts, because all that NC-POD data said that early recognition prompts early management, and those patients have better outcomes. So this is all about doing something early. So what we want everyone to be doing is actioning their alerts. So if you click this button here, you can action your alert, and you can see that you've done something. And it doesn't need to be a copy of what you've written in the medical notes. It needs to be just one sentence, just saying, I've seen this patient, they had a palpable bladder and they've been catheterised and 500 mils has passed. I'll recheck their Usenis tomorrow. So one quick sentence, and every time you do something, you're able to add that as an action. Some of the, when this was piloted in orthopaedics, one of the orthopaedic FY1 said that it was quite useful in their setting because they have quite a lot of turnover of FY1s on that ward. So if you order an ultrasound, you're able to say this ultrasound is ordered, but that alert is still active, so that the FY1 the next day is further pushed to actively chase that ultrasound result. So after this, if you see here, there's a View Actions button, and it's a collapsible list. So if you click that, you'll be able to show all the actions that have happened, or be able to hide them again. And then, so adding notes is not something you need to focus on. That's a bit of a help for yourself if you think that you want to add a note. But what we want to see happening is people actioning their alerts, and then when you're happy that your patient is clinically improving, then you can clear your alert, and then the alert will disappear. In the example I gave you earlier this week on one of the MFE wards of an alert that was generated somewhat in error, you could make an action that this alert is in error because a patient's blood results were taken incorrectly, and clear that straight away. But only when you're happy that a patient's improving, you can clear the alert. The other thing to say at this point is that a lot of these the data we've been looking at shows that the bloods are actually getting better, the creatinine's dropping, but the alert has not gone away because it won't go away by itself. You need to action it, and you need to clear it for it to disappear. So just the conclusions from the whole talk. And I don't know if you want to So AKI is very common, and as Dr. Bell said, there's not a treatment for severe AKI as per se. We can only be supportive. So the focus is on prevention. All that NCPROD data look to say that about a quarter to a third of AKI is completely avoidable, and that's something we can do something about as a generation of doctors. We know nowadays that acute kidney injury increases mortality, and also even with a small rise in creatinine, so those AKI ones, which are just 26 nanomoles rise in creatinine for about 24 hours, will give you a future risk of CKD, and also that there's a potential significant cost saving for the NHS. Any questions?
Thanks very much. So, any questions from the floor?
We've got Ellie here as well to answer the ICE questions.
Professorial question from the back.
Thanks very much. I didn't know about the association of 10% increase in mortality, if I understood you saying that correctly, with a 24-hour period of acute kidney injury. So that's a 10% mortality over what period of time?
Over the lifetime of the patient.
Lifetime of the patient. So I didn't know that, so I've learned something very important. But what is the mechanism of that? It's very hard for me to envisage that. Do you want to talk us through that?
Yeah, so this is what I get asked all the time, and it's not clear whether it is a mechanism that then directly leads to the patient having a reduced mortality, or is it something about that patient that's given them AKI in the first place? Are they more predisposed? I mean, all these epidemiological studies can adjust for various factors, but we can't really tease that out. Is it just, as much as we can adjust, we can't say for sure that these are not just a group of patients that because they are getting AKI, there's something about them that makes their survival worse, if you know what I mean. That's something that's yet to be established.
Samira, is this a weekend problem and an out-of-hours problem? I'm sure people of my generation remember being called at weekends to orthopaedic wards to be told that the patient's not peeing and haven't done for 3 days, or is this happening under our own medical ward eyes and we just don't know about it?
It's happening everywhere all the time, and I think the difficulty is when there's changes of shifts and changes of people, and also people looking at blood results as well. But hopefully these alerts, when somebody looks at the results, they'll see that it's flashing up, and also for nursing staff as well, if they see that their patients are having alerts, because quite often nursing staff look up blood results. It can be a kind of incentive to flag it to the junior doctor.
Is it worth flagging up?
Is
it worth flagging up that on Monday, when this went live, over the course of the whole day, we had maybe about 16, 17 AKI 3s and over 40 AKI 1s across Tayside on the first day. So that kind of puts numbers on it across the patch for everybody.
That includes primary care.
Yes.
And I was going to ask, what's the distribution of these? Is it everywhere? Medical wards, surgical wards, gynae?
Well, I've
GP?
not had a chance to exactly look at the breakdown of it. I mean, a lot of them are in medical wards, but we've certainly that's work in progress. We're looking at the distribution of where these alerts are. Are they being actioned, and what's being done?
Another thing is, so I've looked at some of the AKI3s this week, and sometimes they're very good reasons. Sometimes people are at the ceiling of their care, and we know that they're at the ceiling of their management, in which case you just put that in your alert, in your action, that they're at the ceiling of their management. So it's not that these are all unknown about, but it's just doing something about them.
Samira, that's really a vitally important presentation in terms of drawing attention to the problem. I guess what would be nice to know in a few years' time is whether actually the e-alerts and the other interventions change the problem, because it may be, as you speculated, that what you're flagging up is a marker of physiological frailty, and that it may not be that we can avoid that mortality by simple fluid resuscitation, etc., in the long term. So it would be quite nice to keep this under review and see if you've changed the risk using future linkage analysis, say in 3 years' time.
Yeah, absolutely. I mean, I definitely plan to do a linkage analysis in a year's time, even just to see if the rates of AKI have fallen in community and in secondary care, but also looking at survival and hospital stay as well would be a really useful thing to do, because it's still not clear whether these alerts will make a difference.
Does anyone else have any more questions, comments? Anyone in Perth? The hordes that are in Perth? All two of them? Thanks for joining us. Okay, well, if there's no more questions, then I'll bring this grand round and the whole semester to a close. I'd like to thank everyone who's presented this semester and everyone who stood in for me to chair the sessions, and to all of you for coming. We start on the 14th of May. Look out in your inboxes for the newsletter, and please go on to the college website to subscribe. Thank you very much for coming, and see you next semester.